We all know audit matters in the NHS, but let's be honest, how often does it actually lead to change? Manually reviewing 100 cases in a system of tens of thousands, it's just not enough. In this episode, we explore how that's starting to change. Using AI to analyse thousands of reports in hours and give clinicians the evidence and reassurance they need to act. Welcome to CLEARtalk, the podcast from the National CLEAR programme, where we share insights into how healthcare is evolving, the latest transformation tools like ambient voice technology, and stories from the people shaping patient care. Join us to hear ideas, experiences, and practical approaches, helping healthcare work smarter, safer, and better for everyone.
Hi everyone, my name is Dr. Dan Ratnaraj. I'm a senior clinical consultant at 33N delivering the CLEAR programme, and I'm also a senior NHS registrar. Welcome to the CLEARtalk podcast. Today we're exploring how AI can help unlock something the NHS has always wanted to do but has struggled to do at scale: meaningful audit of imaging pathways. Diagnostic imaging is essential, but it's also expensive, capacity limited, and increasingly under pressure. Clinicians are often making decisions in uncertainty and referring just-in-case cases to avoid missing something serious. The NHS already has mechanisms to audit this, but in reality, those audits are often manual, time-consuming, and limited to small samples. By the time you've collected and reviewed the data, the moment for change has often passed. What this project explores is how AI can take that same audit process and make it faster, scalable, and clinically usable, so we can actually understand referral behaviour at a system level and act on it. Importantly, this isn't about replacing clinical judgment. It's about giving clinicians better visibility of what's actually happening so they can make informed decisions about change. So to kick off, I'd like to introduce our guests today. Firstly, we have Dr. John Jeans, who is a consultant anaesthetist, lead for the National CLEAR programme, and CEO of 33N, who delivered the CLEAR programme. John, it's a pleasure to have you here today.
Thanks very much, Dan. Very pleased to be here as part of the inaugural podcast. Great stuff.
Excellent. Secondly, we have Roger Marlowe, who is our Chief Technical Officer at 33N and is here to add some insights into AI and the kind of design and technical perspective on the project. Nice to see you, Roger.
Thanks, Dan. Great to be here.
And finally, we have Dr. David Rosewarne, who is the brains behind our AI audit programs at 33N in the CLEAR programme. He's also a consultant radiologist working at New Cross Hospital. David, thanks for joining us.
Thank you, Dan. Delighted to be here.
Excellent. So why don't we kick off and start with maybe where this all started, kind of the reality on the ground. Feel free to jump in if you've got things to add, but maybe we'll start with you, David.
Yeah, so I've been a consultant radiologist since 2009, so I've been around the block in the world of radiology, perhaps approaching the end of my time in radiology, but hoping to add something before I depart. I guess we have a situation where radiology, we're trying to provide diagnosis. That is the core of it, and we're trying to provide a scientific basis for diagnosis. So that is the kind of key internal kind of state that we have about what we want to deliver. So when we have a particular diagnostic problem, we need to know, first of all, that the patient is likely to have a diagnosis, and secondly, that the test that we do is likely to provide a diagnosis. So there is a significant difference between, if you like, medical imaging and diagnostic radiology. And I think what we need to do is to try and make sure that we deliver diagnostic radiology for the benefit of patients. The system has become very much bigger over the past 20 years, and I think the people within it have just become essentially parts of a very, very big system that actually no one has any true understanding of. So as doctors, we try and address the needs of the patient in front of us, and that is our kind of core mission as doctors. One faces the patient, one tries to deliver the right care for them. The problem is that when you work in a very large system in which there are unknown factors which are kind of systemic, then that can be obstructed by a wider system. So I think what we need to do is try and kind of bring to bear on individual patients for their benefit learnings that we can derive from the wider system. So that's kind of the fundamental basis of what we're trying to do. Radiology departments are like massive machines which are built in a rather Heath Robinson way. They evolve over time. When one does audit traditionally, perhaps you send a registrar out to have a look, and they kind of turn up a kind of tiny corner of the department. They peek inside, they take some small measurements, and then they go away. And they've only really had a look at a tiny fragment of a big system. These are really big machines that we built. Our department consumes £25 million worth of public funds a year. British Radiology consumes about £3.5 billion worth of investment. So actually, we do need to have some way of measuring the system to make sure that the system parameters are correct. And I think traditionally we've had no way of doing that. And I think the only game in town now is to bring digital transformation into audit and measurement of clinical outcomes. So that's the basis from which I started.
David and I were talking about this problem a few years back, and I think for me the core issue was that in order to get at the data, which is what we need in order to kind of not just look at a tiny part of the organization, but look at the whole thing. To get at the data, it's difficult from a technical point of view because it's all locked up in radiology reports, and it's not structured data. It's prose. It's one doctor talking to another, and so it seemed like a rather intractable problem a few years back, and so that was kind of our starting point, really.
Sure. Can I ask a little bit more about that? I think when you first started this, is before the kind of the advent of the natural language processing capabilities we have at the moment. What were your kind of initial thoughts back then about how you might address this problem, or was it kind of limited to the tech at the time?
Yeah. Well, natural language processing has been a thing for a long time, but it's certainly from the viewpoint of where we are today, it all looks rather primitive. And I think we quickly came up against some of those boundaries. Natural language before AI came along was really difficult to, you could parse it, but it was hard to understand. And even simple things like a double negative could really throw off an interpretation of a report. And so that then kind of you start to think, well, can we really trust what the NLP is telling us about this data? So I think we quickly bumped up against the limits of what was available to us in NLP before AI came along, certainly.
Yeah, it's probably worth saying that probably about three or 4 years ago, we had a little play around with a model called Deberta, which was like a precursor to ChatGPT. That was quite interesting, and it gave a good audit for CTPAs. But the problem is that one had to do a specific model for a given report, whereas actually when the GPT models came along, which people are mostly familiar with, actually transform things. So it makes it much more easy to develop kind of large scale audit across multiple clinical areas, and only with that does it become a viable approach to large scale radiology audit.
Sure. Just to step back a little bit from the kind of the technical aspects of the project and the capabilities of it, and with the actual clinical problem itself, John, do you have any thoughts on kind of where audit stood before all of this, and kind of the limitations of David's kind of mentioned, resident doctors or registrars kind of peeking under a very small corner of the department. Do you have anything to add?
Oh yeah, I mean, I think David sort of has set the premise very nicely. I think as a profession, over the years, we've gone from having very limited mechanisms to audit our practice. I'm talking about 40 years ago. Now, that the main audit that we had 40 years ago, not that I was practicing 40 years ago, but the main audit that we had 40 years ago was people's experiential learning and conversations with colleagues that were generally a bit more informal based, and MDTs were a bit more nascent then. Now what we have, then obviously audit became much more formally into practice as profession. The way that we organize ourselves as a profession medically changed in the sort of 90s and 2000s, and then obviously the GMC guidance changed, and then revalidation came into place. And over the years, we have become more and more formal in structuring the way that we are engaged with audit as a profession. Having said that, I think David's point is very valid. Is that audits? I've got a memory of an audit that I did as an SHO, and a friend of mine. Yeah, no, but we went through notes. We went through 100 case notes. of patients that had non-invasive ventilation to see how many gases they had, so arterial blood gases, and whether or not the patients had art lines. With the case being that if a patient had multiple blood gases on non-invasive ventilation, shouldn't we put an art line in just because it's more comfortable? And then what would the resources be required to manage those patients? And, we probably spent 3 or 4 whole 12-hour days going through case notes. And the reality is that the service didn't change. It was an interesting process. We had a good Excel spreadsheet at the end of it, and we were able to do some analysis and present it at a departmental meeting. But the reality is the service didn't change.
I think it's probably worth saying also that a lot of the fears that people have about missing rare things. So one has this kind of there's a great deal of conservatism in medicine, which is rightly placed in some regards. But people say, oh, we mustn't miss this rare case of something. I remember a patient 3 years ago for which this applied. Now, if we're only doing audits of say 100 people because we're looking through notes, rare outcomes, which are very important, just cannot be detected. And the problem is that actually clinicians don't believe that the data you have is any good. So actually what we need to do to kind of often prove a point that we know in our hearts from long experience, which is that, say, in circumstance X, Y never happens. That's fine. Yeah, we can say that, but people don't believe us. And also the problem is that it's the clinician who is ultimately responsible for the patient. So when the radiologist says you can't have this imaging because it never shows anything, we're just simply not believed. So to actually make that point, one needs to scale up the audit massively, not to hundreds of patients, but to tens of thousands of patients. And I think we're kind of moving towards a situation with the current projects where we're probably going to be dealing with hundreds of thousands of reports. So one generates data which is actually believable by clinicians because it's data which will be harvested from multiple centres and on a large scale and is completely kind of comprehensive. The other thing is that audit typically is poorly done in the sense that audit is supposed to be a cycle. So the registrar who performed the audit back in April last year very rarely is present to do it this year. John, I might ask you, did you complete your audit cycle on that one?
And that's a really good point, David. I was just about to come in because this audit, which we spent a lot of time doing, we didn't complete it.
Oh,
and I think this goes well, but we moved jobs or whatever had happened. But here's the point, right? And this way of doing audit is game changing because it allows you to look at large amounts of data. It allows you to ask different clinical questions of that same data set. It allows you to look at rare outcomes that you can't do with a review of 100 case notes. And it allows you to cycle back through quickly. So you can check after 3 months, and it doesn't take. I mean, to do this will take, to run the analysis and extract the data is an hour's process. So if you look at that, was 4 days of time of two, well-meaning people in their mid-20s trying to build a spreadsheet of arterial blood gases, and we had a genuine need. We cared about patients having discomfort from multiple blood gases. We wanted to stop it. But the or have it managed appropriately. So I think, but that's a huge amount of time. Whereas you can now go through tens of thousands of reports within that time. Obviously, and this is a really important point to make, the technology is very important, but and the way of doing it is very important. The governance around it needs to be tight. So one of the things that is quite tricky when doing something relatively new like this in the NHS is making sure that we have appropriate governance around it and that colleagues across different disciplines feel comfortable and safe in using data in this way. And that's something that I think has been really interesting with this project and how we've gone about that to engage multiple trusts across the country using novel technology, but doing it safe in a way and well governed, because that's absolutely critical here.
Just worth adding at this point before perhaps we move on to governance, which is that one thing that also I think is important is not really not just the fact the audit's comprehensive, but actually in the future we'll be able to do continuous audit as well. So actually what I noticed, for example, in the pandemic, was that actually CTPA requesting went absolutely mad. I think it was in the early part of 2020 when actually pulmonary embolic disease was very kind of common. And actually, there were hospitals in which the system basically went out of control, and some hospitals were doing vast numbers of CTPAs, perhaps 30 or 40 a day. That is almost a department breaking kind of number of examinations. So actually, different systems went into a different form of variation, which actually they didn't really understand at the time themselves. And I think the fact is that we will, in the very near term, we will in principle be able to do contemporaneous, continuous, complete audit of whole clinical pathways, which I think also clinically will be a game changer.
Yeah, I think it's really exciting, kind of what the future holds for this. I think I'll also just pick up a point to what John was saying. I think there really is a bit of a risk of kind of audit burnout, particularly amongst the kind of the resident doctor workforce. You know, we're reaching a point now where there's audit just for the sake of audit, particularly when it comes to kind of portfolio management. But also there is a sense of that kind of nothing really changes, even when I do put in a significant amount of time into collecting this information manually, because as David said, with a kind of relatively conservative space that medicine is, quite rightly so in some spaces, the amount of data that's really needed is massive in order to move the needle on some of this stuff, and the 150 cases that a single clinician or a pair of clinicians are able to look at, unfortunately, often it isn't powerful enough to kind of make that argument. Roger, do you have any thoughts on the kind of the amount of data that we need to really move the dial here?
Well, in some senses, the more the better, and actually, and it's not a problem, right? So we can, that isn't the issue now. The amount of data isn't really the issue. In fact, the amounts of data we're talking about are not particularly large, and when it comes, when you think about other data processing tasks. So that problem has gone away. The size of the audit. I think, other than maybe from a governance point of view, but from a tech point of view, that is no longer an issue. And another thing, funnily enough, that's actually got easier is actually the natural language processing. So when David and I first had a go at this, doing a kind of proof of concept, and we were using the kind of I guess what we'd now see as kind of more old-fashioned traditional NLP techniques, the tech was quite complex to parse and get some kind of meaning out of the report. Now the language models do all that for you. So in some ways, the tech has got simpler, funnily enough. So yeah, I think from a tech point of view, it's actually a relatively straightforward task to do something which is now, but is beyond the reasonable bounds of what human effort could do, really. Yes.
Yeah. So maybe let's ground ourselves in the project that was first done at New Cross, just to kind of explain to listeners what this all means and where the first kind of main step in this process was. David, do you want to take us back to kind of, I guess, maybe what the initial issues were there, and what was done?
Yeah, so I think the particular problem we first addressed was the problem of pulmonary embolism and the management of the CTPA pathway. So we're talking about patients who present perhaps with chest pain, where there's a suspicion that they might have a blood clot in the lungs. And it's the question of how do we deal with that? I think the important thing about these things is not to focus on the tech, but it's actually to focus on the clinical problem as being the primary driver for everything that you do. So when I was a medical SHO, I think there's a system change. So we saw patients with breathlessness, chest pain, etc. We saw them through to discharge. And we kind of knew what the outcomes of every patient were. I think with the fragmented care and increasing levels of, if you like, risk aversion, I would say is definitely leveraged in the system today. So it becomes clear when you're a radiologist and you're reporting these examinations every day, you kind of get to know that the frequency of pulmonary embolism is falling in your data set. You have this kind of picture that the system is going out of shape, but you need to prove that if you're going to change things. And having widely shared anecdotes amongst radiologists is not good enough for actually changing the system. One of the things that I fundamentally think we need to do in health is to actually have a better appreciation and a more rational approach to risk. the present governance in the NHS and the present governance in medicine is rather along the lines of, if a risk can be conceived, it has to be mitigated. Is the kind of current level of things. I think we need to move towards a more kind of quantitative view of that. So this was the kind of the internal model, was that we need to kind of sort out this system and make it kind of quantitative. We need to turn essentially bodies of text into statistics that we can then work with. So that was the kind of origin of it. I think it's also true that it's not just radiologists who feel that the system had gone out of shape. I think clinicians do as well. They also know it, but they are in the firing line for cases of missed pulmonary embolism. So they are even more risk averse than radiologists in their kind of behaviours. So I think we were, to some degree, pushing on a slightly open door. People wanted to make the change, but they wanted to be enabled to make the change. So in New Cross, this kind of went through the Trust VTE committee, the committee which deals with thrombosis and thromboembolism. So they were kind of almost thinking that they wanted to change their D-dimer regime from which is the kind of screening test for pulmonary embolism. So people come in, have a blood test. If the D-dimer is below a certain level, and they're not thought to have a high clinical risk of a pulmonary embolism, that's considered to be good enough to say goodbye to the patient. Mm-hmm. So that was always the kind of the clinical process. But there are kind of thresholds to choose for the D-dimers. So there's been a traditional threshold which we've used for a long time now, since I was medical SHO. But more recently, some trusts have gone to using what's called age-adjusted D-dimers, which is slightly more relaxed kind of position. Our clinicians basically wanted to do that, I think. Okay. And then there was a kind of serendipitous collision of our audit process with actually their process as well. And I think by doing the large audits and presenting them with data which essentially confirmed that they will be safe to go to age-adjusted D-dimers, it just enabled them to do what they always really wanted to do in any case. So it was a kind of a sweet spot and a serendipitous collision that enabled it to happen.
Yeah, what do you think were the barriers prior to the audit, kind of in them implementing an age-adjusted D-dimer?
Well, I think it's just risk aversion. Actually, I mean, I think is the fundamental thing. People just don't know what the risk is. So mm-hmm. the risk could be anything. They know it's small, but they don't know how small it is. They don't know what the consequences of change will be. They know that they might well be in the firing line if a process is changed and there's a bad outcome. They really kind of feel, I guess, vulnerable. And at least, there are no guarantees that the PEs will always be trapped. There is no system which will trap every single diagnosis all the time. This is a kind of position that people do understand intellectually, but they don't actually believe in their guts when they're dealing with patients. So I've heard, for example, hematologists at other places say things like, "We must never miss a pulmonary embolism." That is just not a realistic aspiration. We must have essentially what we regard as being a decent sensitivity for detecting pulmonary embolism that overall gives you a safe pathway. But we cannot detect them all, because the flip side of detecting them all and treating them all is that patients will be harmed by anticoagulating them. So the treatment for PE is to thin down the blood. But we know that the patients who have blood thinners on board are more likely to have gastrointestinal bleeding, intracranial hemorrhages, etc. Yeah. So there are harms related to diagnosis and overdiagnosis, and so it's fundamental to getting the right kind of outcomes is actually having measurements, knowing the system you're dealing with, and balancing the risks and the benefits.
Yeah, I mean, there are consequences to action and there are consequences to inaction as well. I guess let's open up the kind of governance and safety conversation then, because I think that leads in nicely. I think we'll go to John first and then to Roger from a technical perspective of how you make sure this is safely done and safely interpreted. John, where do you think we kind of sit from like a safety perspective on all of this and getting clinicians to trust it?
So it's a spectrum. So I think there's two elements to this. Is enabling colleagues to feel confident in the results and outcome is one element, and then having appropriate governance around it so that we are confident that the right data is being taken out and in the right way and shared and used appropriately and deleted in a timely manner.
Mhm.
And that's with appropriate safeguards. That's the second element. So I'll probably talk about the second one first and the first one second, because
Sure.
it's a bit quicker with the first one. The second one, I think from a governance perspective, we in the NHS have had GDPR in for about 8-9 years now. There is a way that you can share data, as long as it aligns to the GDPR principles and the wider information governance frameworks that we use in the NHS. So I think the risk from if you do that properly and have appropriate DPAs and DPIs in place, architecture that is safe and secure, which Roger can talk to in more detail, then I think the actual governance of sharing this type of data is, I wouldn't say straightforward, but is entirely achievable and can be done in an effective manner. From a clinical perspective on how you can be assured of this data, I think there's something about the way that you use this data. So what you can do is you can ask it a specific question. Is a PE present, yes or no? And if a PE was present, what was the D dimer when that PE was present? The two things that I would have in my clinical mind on this one is, how accurate is the AI at saying whether there is a P present or a P not present?
Mhm.
And what you would need to understand from that, after asking that question, is you'd also have to compare that to how accurate would a doctor be if they were reading through a report and saying whether a P was present or not present. Now, I'm not a radiologist, but I would imagine that there's probably a 1% error rate in reading scans. David, you'll be able to sort of say if it should be 1%, 3%, 0.1%, but there'll be a 0.1 to 1% error rate in reading scans for diagnosing whether a P is present, something along those lines. Effectively, what you do is there is a way that you look at processes like this and you decide whether or not they're safe. What you do is you take a sample size, and that sample size has been read by a computer and then given you an output. And then you take let's say that's 10,000 scans. You then take a sample of that, 1 or 200, and you run that through a couple of people. And you say, here's the report. Do you think a P is present, yes or no? And then you compare that sample size, and provide it's a statistically significant sample size, you'll then be able to have assurance that the AI is giving as good as reading as a human. That for me is the key benchmark. Once you've understood that, you can then have confidence in the questions being asked of the data for that specific use case. And then once you do that, you then have to put it through appropriate clinical governance processes within your organization. And that clinical governance process, although it does take a little bit of time, get some brains around the table. And some brains around the table look at the evidence and decide whether a pathway change is merited based upon the data. So I think from a data sharing perspective, which was what I alluded to at the beginning of the helpful question, Dan, is I think that stuff is entirely solvable, and it just needs to be done in the right way, thinking about the patient and how the patient owns their own data first, putting that as the premise. The second question of how do you act upon it clinically, you look at the outputs, you then take statistically relevant sample sizes, you make checks based on those, and then you take it through appropriate clinical governance process. It's just how we do any clinical change in the NHS, and provided you hold true to sensible, reasonable, structured decision making, you will get a good outcome for your patients, which is what we're all here to do.
Yeah, Roger, do you have anything to add from sort of a data sharing perspective?
Yeah, I mean, as John said, GDPR's been in effect for a while now, so there were already well established governance guidelines and technical approaches for dealing with data which may contain personal identifiers. Actually, for this work, we don't need any personal identifiers. So again, that's another way to de-risk it, is we can strip all that out to start with. So we can be very confident that there's there are no risks from that point of view. I guess the other thing to point out is with Audit that we're looking at data in aggregate here. So this is absolutely not about individual clinical decisions. This is that we're avoiding that risk as well. So there are various ways to look at this to kind of to de-risk it, and we already have all this kind of machinery and governance for handling this data. So that's, again, from a tech point of view, that's been relatively straightforward.
Yeah,
Yes,
I think there's an element of kind of concern when people hear AI or radiology or radiology reports, particularly with the amount of existing work that's going on into reading images and making diagnoses, clinical decision support, those kinds of things. And I think it's been really important throughout this whole process to make sure that we are clear on what we're talking about here. We're talking about retrospective, service evaluation that is bolstered by the use of AI and its ability to look at many more scans than a human would be able to do in that period of time.
Totally. When we started this and AI first came on the scene, everybody was worried about hallucination, and it was a problem. But this technology is moving so quickly now that problem is really diminishing now, and we've also got a very good understanding of how it operates and how things like prompt engineering can really help with that. So we've really learned a lot through this whole process. David, I know you've got some thoughts on that as well.
Well, it's really just to say that clearly radiology is one of the areas which AI has been first and foremost in, and people have talked about AI to do things like reading chest radiographs, reading CT scans, that kind of thing. That is really high risk stuff, and also is very expensive. So to develop those kind of models that read chest radiographs might involve hundreds of millions of dollars investment. There's a lot of regulation, and one is dealing with individual patients. So if the diagnosis is wrong, that has high stakes. One should actually look at these tools, the language models. These are the most expensive software programs that have ever been developed. The scale of investment in these is absolutely huge. If you look at the big two, perhaps Anthropic and OpenAI, probably $100 billion of investment has gone into these to make them perform in the way that people desire. We have an incredible opportunity to leverage the investment that has gone in these models in the work that we're doing. In my view, this kind of analysis of text is far more powerful in terms of its impact on the health system and its ability to do good than is, for example, any single application, because they are just so general. Everybody talks, everybody uses language. Everybody needs that language to be kind of categorized and turned into numbers to be made into part of a system which works better.
Yeah.
Another surprise, by the way, that I don't think we anticipated when our AI first came on the scene. We went from having to use NLP tech to just parse English and try and extract some kind of meaning, such as is this a positive report, is it a negative report? Suddenly that became much easier with language models, just because they understand language. What I don't think we realized at the time was you can also ask them, is this a good quality report, or is this giving you a kind of indeterminate outcome? Because radiology reports really ought to be quite specific and pointed. But you can say, well, is that a good quality report? That's just totally beyond the realm of that old-fashioned NLP technology. But we can actually kind of extract that kind of data as well now. So that's really exciting too.
There are some departments which, for example, insist that people don't use words like probable in their reports, but it creeps in, and actually that's a problem which will be cultural in a department. So actually, indeterminate reports in which the clinician doesn't actually know what the report means are a significant problem, and that can be measured. We can probably ask the model to if you like analyze perhaps 20 features of a report in one go. Even with a small audit with people would just get kind of confused, distracted, start to make errors just because they get bored. I'm afraid one of the problems about audit is that it is quite boring. It's important, but people get bored. And that is understandable, because it is quite boring. But what isn't boring is the lessons which can be learned from audit. So that that is the transformation. We've got an army of little kind of digital elves to help us out, and we're the shoemaker who turns up in the morning. Typically, you'll press enter in the evening, and in the morning you have a lovely audit with tens of thousands of patients categorized. It is just that fairy tale come true.
Audit Santa has been overnight, and you've got your presents to open in the morning. John, that kind of opens up the question of the kind of the quality assurance side of this. We've got the CT colonography program running at the moment as well. Do you have any thoughts on kind of where that could go, from not just assessing how a service is running and maybe how clinicians are acting within a space, but providing that level of quality assurance to something like CT colonography?
I mean, it's a very, very interesting space, right? The way these models can be used are far broader than just, is a diagnosis present, yes or no. I think we've already alluded to the fact that does a report contain these 5 features that we want to contain, yes or no, or which of the 5 features does it contain? We can start to get into more and more detail about that. Now, I think it's really important here is that what we're not looking to do is we're not looking to sort of grade someone's report, because there is variability. I mean, I'm not a radiologist, but I've looked at enough chest x-rays over the years to be sort of thinking, okay, I think that's some haziness in the left lower zone, and I think that maybe that's a sign of pneumonia, and yeah, sure, we'll start them on some tazocin or whatever, and if they're an IT or whatever it may be. But but what you can do en masse when you look at these reports is start to sort of say, look, what are the features that are commonly present in a report?
Yes.
And if these features are present, do we think that it aids a colleague in making their management plan tangible and actionable or not? Because I think one of the things we do have to do when we look at ourselves in our clinical practice is say, who are we serving? In my job, I serve 2 people. I serve my patient and I serve my surgeon. My job is to make sure that my surgeon can have can do a good operation to whatever I can do to support that. My job is to support my patient to make sure that my patient can have a good operative outcome. And a safe anesthetic. In any clinical discipline, and I don't know who, I mean, a radiologist will serve multiple people. It will serve the patient, it will serve the referrer, it will serve the organization, the general public. But if we can help people do a better job for the colleagues that have asked them a question, or for the patient who is going to be the beneficiary of any treatment, and that comes through more structured reporting on how we should structure reports within different clinical areas, that's actually quite a helpful mechanic to improving the way that we deliver care. So I think the key point to make here is that when you look to quality assure the way that reports are done, it's not about saying to someone, this is good or this is bad, or you're doing it right or you're doing it wrong. It's about saying, how do we give the best possible outcome from the knowledge that you as a specialist have, and so that those outcomes benefit the patient and the person who's asked you a question.
Yes, completely. I think maybe we'll sort of aim to wrap things up now with a question to all 3 of you of where you think maybe this goes in the future, what this looks like in the next maybe 6 months, in the next couple of years. Maybe David, we'll go to you first.
So I think in radiology, we are already kind of starting to look at multiple pathways. So I think we need to expand the range of investigations that we look at. There are we're concentrating really on a lot of inpatient investigations because acute radiology at the moment is particularly problematic. But the same applies in outpatient settings, in general practice, etc. So my view is we should start by looking at where our costs are, and where people feel that there's less value in a lot of the imaging we do, to try and bring that back. So I think over the next year we'll probably expand the range of audits that we do, and essentially create what is a series of digital audit recipes for major pathways. So I think that's one aspect. One thing also is that we kind of want to expand out the kind of the application to wider numbers of organizations, because actually one of the kind of key things is that it's in detecting unwarranted variation between different places that we're actually able to then find the best practice. So we've already observed in a number of places, for example, there are times and places when people were achieving quite good categorization rates and positive rates in PE imaging. So more than 20%. There's an RTR standard that is that it should have a yield between 15 and 35%. So 20 odd percent was well within the range, but that was some time ago. The past is another country. They do things differently there. That's a quote. Actually, the past was a different country in healthcare, but it had some good features that perhaps we can bring back. So the analysis of variation across time and across different places, I think, is fundamental to it. We're currently perhaps doing, a scale of 10 centers at a time, which will give us a lot of learning. That's kind of 10% of UK trust. But I think what the ambition would be in the future would be, continuous, comprehensive, wide-scale audit of multiple pathways in radiology. The same applies also then to other things like endoscopy, other single text type of entities. So other endoscopy, cardiology tests, etc., would be the kind of thing one can do. EPR is growing across the system. One can eventually think about doing wider multi kind of modality data with a combination of text and blood test results, for example, to improve clinical pathways. I think that's, that will probably keep us going for the next five years, in my view.
Excellent, exciting stuff. Thanks, David. Roger, do you have any thoughts, I guess, on the same question and maybe the speed at which the tech is growing at and where you see it going?
Absolutely. I mean, I think it's commonly said in tech that data is the new oil, and just to run with that analogy for a moment, I mean the data can be in difficult to access places, right? In the same way that crude oil is, under the seabed and so on. And just as the crude oil needs all sorts of processing to really open up its value. So in the world of data, the really valuable stuff is actually in text, right? In plain text and also in voice. And those have been previously inaccessible places in the same way that crude has been inaccessible. But with the arrival of LLMs, it's really unlocked all of that. So now all of that kind of value can now be extracted and distilled. And honestly, the sky's the limit. I think we're really just starting with this. And that tech is moving extremely quickly as well. I mean, there are all sorts of things happening which we just couldn't anticipate. I mean, even in this radiology example, we thought the arrival of LLMs was great for parsing the radiology reports. What we didn't anticipate was that we could use the AI to write the software to run the workflow around the whole thing as well. So we had that we didn't guess that either. So it's helping in ways we couldn't even anticipate, and that's just in the time frame measured in months. So I think the future is very exciting for this area.
Amazing. And John?
Yeah, no, I to build on that, I mean, one of the things that we are really good at as humans is we're really good at seeing things that operate in a linear manner. So that means, I've gone from 1 to 2 to 3 to 4, or from 2 to 4 to 8. As humans, we are not very good at exponentials. So when COVID came, I remember having conversations and being on meetings in January 2020 with colleagues in Italy, and they said, it's coming. Get ready. Be aware. It will start off as everyone getting a cough and cold, and then your ITU will be overflown. What we saw there was exponential growth. COVID grew exponentially. Now, the point here is not to say that AI is a virus. That's not what I'm trying to say. What I'm trying to say is AI's capability is growing exponentially. And the point is that as humans, when we look at exponential capability or exponential activity, everyone says, oh my God, I never saw it coming. And that's what everything happened with COVID. Everyone said, oh my God, I've never seen that. I never saw that coming. And we are in a similar vein with AI in terms of the capabilities that it's growing with. AI is currently getting better at about a rate of 4 times a year. So the AI that we will have next year, 1 year from now, will be 4 times more powerful than the one that we have this year. That's currently what we're seeing. Now that's substantial. That's historical trends, by the way. That may not be how things pan out, but based upon historical trends, that's what we've seen. So I think what that means is that we have a duty to our patients to use this technology well, and we have an opportunity to use this technology well. But I do mean use well, and that means appropriate governance, appropriate safeguards, thinking cogently about how we take the insights from the audit that's been run overnight, and then apply them so that we can improve the care that we give our patients and the outcomes our patients receive from the healthcare system that we have.
Thank you, John. That's really interesting. I think today's conversation really highlights that the drive to bring about this change has always been there. It's always been there, existing in anecdotal conversations over a cup of coffee in the break room or whatever it may be, over an SHO. I won't name who it is. It's myself, complaining about why things can't change because they know that something exists within the system, but they don't have the ability to kind of prove it because the power that's needed, the amount of data that's needed, just didn't exist. It wasn't accessible. And now we really have an opportunity to kind of showcase that on a massive scale. But as you said, John, doing it in a safe way that makes sure you've got those kind of guardrails around, because everyone understands the concept of garbage in, garbage out, and we need to make sure that any changes that kind of occur off the back of this occur with reliable data that you can really trust and insights that have been validated and that clinicians can get behind. Thank you all for your time today. Really, really appreciate it. Thanks for joining the first CLEARtalk podcast, and hopefully we'll see you again next time.